Let's start with something every practice administrator knows but rarely talks about. Right now, there is money sitting in your accounts receivable that belongs to your practice. Valid, billable coverage. Claims that should have been filed months ago, but because a patient simply said, "I don't have insurance," or because your team was too busy to dig deeper, those accounts get written off as self-pay or sent to collections. To understand the staggering national scale of this problem, look at this chart tracking revenue losses across U.S. hospitals. Based on 2025 data from Kodiak Solutions, the cost of denials and uncompensated care jumped from $38.6 billion in 2024 to $48 billion in a single year, and the proportional damage hits private medical practices just as hard. As this visual morphs into a pie chart breaking down bad debt, notice this 5% slice. A widely cited TransUnion Healthcare analysis found that up to 5% of self-pay accounts written off as bad debt actually contain hidden, billable insurance coverage. Let's apply that to a typical practice generating $2 million annually. According to Healthcare Financial Management Association data, hospitals lose an average of 4.8% of net revenue to denials. For that mid-size practice, that means nearly $100,000 a year is quietly walking out the door. Missing coverage is a primary driver behind those denials. In Experian Health's recent State of Claims survey, nearly 20% of providers, 1 in 5, report losing revenue specifically because they could not locate the correct active insurance plan at the right time. Undetected coverage represents an operational blind spot that quietly drains thousands of dollars from practice margins every single month. The environment for medical billing is growing increasingly hostile. Over the last few years, medical group leaders have reported a continuous, steady rise in claim denial rates across the board. This line graph tracks that precise upward trend. According to Experian Health, back in 2022, 30% of providers reported claim denials exceeding 10%. By 2025, that number climbed, with 41% of providers now seeing their claims denied more than 10% of the time. Initial claim denials are particularly unforgiving. When coverage isn't verified correctly before a claim is submitted, you don't get a second chance to make a clean first impression with the payer. Instead, you get a stack of paperwork and a resource-heavy rework cycle. The root cause of this blind spot comes down to staffing. This organizational chart highlights the continuous turnover in medical billing. MGMA data reveals a 32% annual turnover rate for billing staff, alongside an expanding timeline that has grown from 35 days to a staggering 68 days just to refill an empty seat. Even when a seat is filled, the training deficit is severe. The median onboarding period for new staff is just 2 to 3 weeks, completely insufficient to build the deep expertise required to navigate the complex, contradictory rules of 40 or more different payers. Then there is the true financial burden. When you factor in salary, benefits, training, and the cost of replacing turnover, a single in-house billing full-time equivalent runs between $55,000 and $75,000 per year. Relying on an in-house model for dedicated insurance discovery is mathematically broken. It leaves practices vulnerable to compounding revenue losses while struggling to maintain basic operational stability. The practices successfully capturing this lost revenue aren't relying on magic. They execute a strict, repeatable set of protocols designed to catch missing coverage early. The first critical rule of systematic discovery is timing. You must run comprehensive coverage checks 24 to 48 hours before the patient even registers, catching changes before they become permanent write-offs. This flowchart illustrates the necessity of multi-layer searching. When a patient claims they have no insurance, the inquiry doesn't stop. It branches out into multiple, simultaneous verification streams, checking Medicare, Medicaid, state exchanges, and secondary policies as entirely separate, mandatory steps. But discovering the insurance is only half the battle. Finding the right payer is only useful if paired with thorough claim scrubbing, ensuring the claim is submitted cleanly on the very first pass. Because of the intense labor required, smart mid-sized practices are abandoning the impossible math of the in-house model entirely. Flow to dedicated, outsourced teams embedded directly within their existing EMR system. Effective insurance discovery requires dedicated ownership. When treated as a secondary task by a busy front desk, it becomes no one's priority, and the revenue slips away. Staffingly provides a direct solution by assigning a dedicated, credentialed specialist to work inside your EMR every day, free of usual HR overhead. And as this digital vault door sealing shut represents, the team operates strictly under SOC 2 Type 2, ISO 27001, HIPAA, and HITRS compliance frameworks. We can compare the exact financial math on this balancing scale. On one side, the in-house equivalent costs a minimum of $55,000, and often up to $75,000. On the other side, Staffingly's dedicated service runs roughly $20,000 annually. The transition is immediate. Onboarding moves from mapping your EMR and payer mix to a fully operational go-live in 14 days. Then the dashboard shows AI augmenting the workflow. Smart routing prioritizes accounts, while automated audits push the error rate below 1%. This model is frictionless. Practices can test the system through a 14-day risk-free pilot, and all engagements operate on month-to-month contracts, so you can easily scale up or down with 30 days' notice. Protecting your practice margins requires an airtight operational system designed to stop